Welcome everyone to today's COPD webinar. I'm losing track, it's our third one, isn't it? And welcome to Jackie and Famida, who very kindly are going to take us through this. We've got this LTC webinar series and we have heart failure in the beginning of the new year, with some others coming next year as well. So that's really exciting. So Jackie and Famida, if you want to kick off, thanks very much for today.
Thank you. Some of the people in Barnet will know me well. I'm Jackie Hodgson. I work in a GP practice as a nurse practitioner, but I've been involved in Barnet Care Primary Care Training Hub for the last 6 years. This is going to be our COPD Whistle Stop tour. I'll let Famida introduce herself.
Hi, everyone. My name's Famida. I'm a practice-based pharmacist, although originally background in community pharmacy. Like Jackie, I also work for Barnet. I also work in Barnet and do some work for Barnet Training Hub as the pharmacy lead. My background is in respiratory medicine as well. Thank you.
Okay, shall we kick off with the first slides? So similar to the one we did with asthma, the aims of the session, we're just trying to do a very brief overview of what COPD is, its diagnosis and objective testing, and look a little bit more detail about how we can do that during our COVID period of time. Some information about the management monitoring, some of about essential COPD reviews, treatment choices, which Famida will be doing with the pharmacy side, and some guidance throughout there about remote consultations. We followed this SIMPLES SIMPLES mnemonic, which throughout the presentation there'll be references to smoking status, inhaler technique, investigations, monitoring, pharmacotherapy, lifestyle, education and support. And that's really important when managing any of the respiratory conditions. Thank you. Next slide. So what is COPD? I mean, hopefully we all are aware that it's a long-term condition. It is very much an umbrella term for a group of lung conditions. It does include a group of lung conditions, including emphysema and chronic bronchitis, characterized with airway inflammation, obstruction, which is not fully reversible, damaged and collapsed alveoli, and it, as the name says, is chronic and progressive. And this little cartoon is, I mean, years ago we used to refer to patients as pink puffers and blue boaters. And so the difference between the two of them really is those chronic bronchitic, the blue cartoon character there, it's characterized by 3 months of the year with cough in 2 consecutive years, whereas the emphysema is much more of a pathological diagnosis with chest x-ray showing hyperinflation of the lungs. And actually, quite often some patients with emphysema may have normal lung function tests. Next slide, please. So I won't read these out in verbatim, but the definitions are there for everybody to look at. There are 2 main standard guidelines, GOLD and NICE, and both of them really do characterize the fact that it's airflow limitation, it's not reversible, and usually progressive, mostly caused by the lungs to have inhaled noxious particles or gases. And as we are all aware, that's very, very likely to be smoking, but quite often can happen with people in other countries who've been cooking on open fires. That can also cause damage. And there's an inflammatory response in the lungs as well. Thank you. Next slide. So there are a few types now we're beginning to see of COPD, and actually having it laid out like this is quite clear. You can see that difference that we were talking about earlier with emphysema. Emphysema being the little alveoli sac there that have gone from those lovely bunch of grapes to being quite coalesced together and reduced surface area for the oxygenation to take place in the alveoli. And then the top picture there, which is the chronic bronchitic with the inflammation on the airway and the excessive mucus production. There is an overlap in some of these conditions, as there is an overlap in patients with asthma, and some patients with asthma have fixed, irreversible lungs as well. The emphysema, there are a handful of patients, and this is very rare, but 1% of patients with emphysema may be diagnosed under the age of 40, and they may have this alpha-1 antitrypsin deficiency, which is a genetic predisposition of getting COPD. It's quite severe, and some patients that get that, the prognosis is not very good, and they are quite symptomatic. And then a little box at the bottom, just as a reminder to everybody that we need to be thinking about diagnosing, and bronchiectasis is often misdiagnosed as COPD, but that's just a bit of a reminder for everybody. Okay, next slide, please. So this is a little bit of just a reminder that the COPD, the problems there as by the British Lung Foundation, saying there's 1.2 million people in the UK that are living with COPD. And something that's not on there, just to highlight, is actually 2/3 of the people may well be undiagnosed. So it's about getting the correct diagnosis and finding some of these patients. 4.5% may have a diagnosis of COPD, and at the moment there are more likely to be men than women, but with smoking increasing in women, we may never know, that might change the bias. It's often associated with other lung conditions as well. And this is the second most common lung disease after asthma. Next slide, please. A little bit of the next ones we're going to go through are around about the diagnosis and have we got that correct diagnosis, really important. And just to guide for those people working in primary care, that the new COPD 2021 guidance is saying that, you know, evidence is required to get diagnosis of COPD correct. Next slide, please. We're not going to go into spirometry too much, but we can't do a COPD talk without mentioning the gold standard definition that you have to have to diagnose COPD. There's actually airflow limitation defined as post-bronchodilation, FEV1, FVC of less than 0.7. And that means after a bronchodilation of usually 4 puffs of salbutamol via a spacer, recorded 20 minutes later. At the moment, as you know, spirometry is not happening. We will talk about that a little bit later on as well. So there is the evidence and the codes in the EMIS to code as suspected asthma. 2021, the ARTP are suggesting that everybody who's performing spirometry should have be on a correct register, and that we know that they are healthcare performing and are interpreting the results, do hold a valid and current certificate of competency. And you can register there with the ARTP for specific training and guidance about that. So we know that it's to be reversible. We were looking at if it's not reversible. So if it's more than 12%, it actually may well be asthma, but it can sometimes be seen in COPD. There is a little bit of reversibility thinking about that. And FeNO can sometimes be useful as well, which is the fractional expiratory nitric oxide, so that we could rule out asthma when we're doing those tests, to say that actually people with levels of over 40 are more likely to be asthma. So it's just sort of like trying to put a little bit of a jigsaw piece together to try and pick out the correct diagnosis. The bottom there, the little picture, is the lung function flows. And as you can see in the blue line there, we've got obstructive disease with the sort of bowing down of the graph and the reduced lung volumes. Any questions on that? Next slide then, please. So this is sort of a bit of a pragmatic way of looking at the COPD diagnosis during COVID. Thinking all the time about symptoms when you're doing your history taking, the cough, the dyspnea, the sputum production, chest tightness and wheeze, and do they get frequent winter bronchitis? What's their history? Don't forget 90% of patients with COPD were smokers or ex-smokers, so please check anybody who's registered as an asthma patient whether they were a smoker and if they've had lung function tests. We also need to be thinking about secondhand smoke, other drug use, illicit drug use can, certainly with marijuana, can cause problems with COPD. Is there an occupational exposure? The genetic factors I alluded to, which is the antitrypsin factor, the alpha-1 antitrypsin, and anybody over 35 and smoking, we should be considering it. Although spirometry is essential, the comprehensive history in COVID time is really key to this. So at the moment, we know that we can't do the objective testing, and I know there's some work being done with the Royal Free about how they're going to begin to open up the services, but in primary care, we're not being advised to do this. There is some talk about doing it in car parks and we needing proper airflow. So primary care, not at the moment. We can look to our secondary care colleagues to think about, do we need to refer to scans? Do we need to refer to secondary care? Check a full blood count. That really might guide us to see if there's any raised eosinophils, which may be more related to asthma than COPD. Checking their BMI, their oxygen saturations, and peak flow, thinking about peak flow diaries and actually doing a 2-week peak flow diary. And if they don't have any reversibility, then coding as suspected asthma, that might be a good way. And if it's less than 75% of their expected or best. And we've also got the system questionnaires, which are the CAT scores and the MRC questionnaires. I'll show you those a bit later on. Next slide, please. So this is just the position statement from the Primary Care Respiratory Society about diagnostic work. There we get the information about the under 75% predicted suggested degree of airflow obstruction. And when trying to assess the COPD, that serial measurement over 2 weeks that does not vary, but also remains low despite salbutamol for symptom relief, would suggest fixed airway obstruction and is suspicious of COPD in the context of supporting the clinical history. And it is important in people suspected of having a COPD to rule it out because of other causes and other symptoms that may require different treatments. So that's the reference for you for a little bit more details on that. Next slide, please. So we've got gold and we've got NICE, and again with respiratory, but there are 2 guidelines, and to sort of try and not make it too complicated, we sort of go with the sort of pragmatic view that gold is a really great assessment tool and thinking about diagnosis, and you'll see when later on Famida will allude to that NICE is a much better, clearer tool for treatment pathways. So here we go on the left, we've got our spirometry diagnosed confirmed with the FEV1 percentage predicted less than 0.7, and then in gold it classifies it into 1, 2, 3 and 4 depending on the percentage predicted. And then we do need to be thinking very carefully about exacerbation history and hospital admissions when we're trying to code them into this A, B, C or D scale, looking at the CAT scores of less than 10 or more than 10, or the MRCs as well, and how many hospital admissions. And then once you do that little calculation, it's very easy to do using the links on the computers, classifying and coding on the EMIS as gold, A, B, C or D. Next slide, please. So this one and the following one are the different assessment tools. Again, there's a link in the templates in primary care for the CAT score, which is the COPD assessment screen, and it's asking the patients to quantify on a scale of 1 to 5 how much their cough, their breathlessness, their symptoms impact on their life. Next slide, please. The MRC scale has decided everyone to be making it a little bit complicated, but just for QOF purposes, the MRC is the one that's on the QOF scores of 1, 2, 3 or 4. NICE do suggest the modified one, but don't worry about that. Carry on doing your coding on the computers with the MRC. Next slide, please. So thinking about getting a little bit more of the sort of where we go and how we get things right. The NHS long-term plan noted with this is the London Clinical Respiratory Network work that it is so important to get accurate and timely diagnosis, and that is to stop well, it's to get correct treatment pathways as well, which then leads on to correct prescribing and use of medications. And there is a huge responsibility of respiratory prescribing. There is a huge amount of money spent on inhalers that may be inappropriate and money not well spent. We know that pulmonary rehab and activity in this group of patients is really key, and we need to be promoting that as much as possible. There have been poor completion rates in a lot of the services that have been provided with pulmonary rehab in the past. Obviously, smoking, treating tobacco dependency is the first most important thing we can do to help this disease progression moving forward. Encouraging flu and pneumonia vaccinations. Interestingly, healthcare professionals do have a low uptake in flu vaccinations, and hopefully we will all be saying yes to the COVID vaccine. And then other areas with the NHS long-term plan, they were looking around pollution and sustainable prescribing, so helping with reducing air pollution and thinking about the public health implications and sustainable prescribing, moving more from the MDIs and the environment to the powder inhalers. Thank you. Next slide. So what does a COPD review look like? So this is the NICE guidelines, and it's fairly simple now. They've updated the guidelines. They were out of date for a little while, but they are really clear now. We've got this confirmed diagnosis of COPD, and I really stress again that it is a confirmed diagnosis. We've got that right. And we're looking at smoking cessation, pneumonia, vaccinations and flu vaccinations. I do know there's a national shortage of pneumonia vaccines at the moment, so that might be going on until the spring next year. Pulmonary rehab, and I think some of the services suggest that an MRC score of over 3 before you refer. But our local service in Barnet, I do know, accept people less than MRC under over 3 because they will accept people who are motivated to attend, which is great. They are still doing pulmonary rehab. I'll explain that a bit later. Thinking about developing a personalised self-management plan, very similar to what we do with asthma, and I think probably not done as well and not done as often, but thinking that we should be doing this a lot more, and it's written down, especially with our patients that we're not seeing so often anymore. And obviously thinking about all those other comorbidities in this group of patients. Then we think about starting inhaled therapies, and Famedia will go into that in a lot more detail. And every time we see them, checking inhaler technique before we step up. Okay, next slide, please. So this COPD talk again, banging home the importance of the non-pharmacological parts of COPD management. If you look at this pyramid, this is the 2012 quality of measuring the quality of life, really, that we can actually do so much more for our patients at the bottom of that pyramid, and it just reiterates some of the other points that I've made. And at the top there, we've got triple therapy, less patients and more expensive from what we can do with all of those flu vaccinations and preventing people from getting sick in the first place. Next slide, please. Just a little bit, there we go, about flu vaccines and COVID. And the next slide. So smoking cessation, I wanted to go a little bit more detail about smoking cessation. This is what I do with my patients to support them in stopping. And I go back to this Fletcher curve that was done in the 1970s, and it is still very relevant. You know, starting off there on the left-hand side of the axis, somebody's lung function age 25, and it goes down normally with age. Even if they're a non-smoker, if they're susceptible. And then if you start smoking, you can follow the red line trajectory down and say to patients, well, here we go, look, even if you stop at 45, you can reduce the impact that smoking can have on your lungs. And even at 65, stopping smoking will prolong your life. So it works. It's quite a good sort of visual for people to actually get to grips with what they can do and how they can, you know, stop damaging their lungs, really. And then a little bit underneath there is thinking about what a pack year history is. So thinking about anybody who's smoked greater than a 20 pack year history does have a significant impact on developing COPD. And that is calculated by multiplying the number of packs of cigarettes smoked per day by the number of years the person has smoked, and anything over 20 is a significant number. And so thinking about that when we do our smoking cessation advice. Next slide. So 9 in 10 cases of COPD are thought to be attributed to smoking. So again, we can't not say to anybody, we have to say every consultation, the ask, the advise and the act guidance about smoking cessation. So please, if you're not smoking cessation trained, please do the training from the NCSCT. Next slide. Pulmonary rehab, I talked a little bit about that before, but a little bit more detail here. The evidence is there that all the evidence is that pulmonary rehab improves patients' ability to function, their ability to walk further, their quality of life, their anxiety and depression, and their knowledge of the conditions. And they're normally 6 to 8 week courses. And I do know the different areas and have different service delivery. Camden has a service, and they have lots of information on their website. And I know Barnet at the moment are doing their first one face-to-face, and then they're actually sending patients away with some virtual classes to do. Also tap into the British Lung Foundation guidance. They have some really good patient information about Breathe Easy and patient passports. There's some great home videos you can send links for the patients to, and then some strengthening exercises, and they're all geared to different people's abilities. Next slide. This is Nottinghamshire's COPD self-management plan, but I thought it sits quite nicely in how we do the asthma one. You can develop your own locally if you wish to do so, but I think it's something that we probably don't do as well in primary care as we could. Something just to think about how you do your patient's personalised asthma plan. Obviously, knowing when to take antibiotics and when to worry and when to have steroids, I think Famida will touch on and talk about later. Next slide, please. The Primary Care Respiratory Society released this at the beginning of COVID, and they thought that it was really important for the patients to have an emergency inhaler treatment pack. And this is what they suggest is in that treatment pack, and how patients can access and help and support. So Primary Care Respiratory Society is my go-to place for all the up-to-date information. So have a look at that in more detail. Next slide, please. Unfortunately, because of the people with COPD and their age. We have a lot of comorbidities to consider when we're thinking about COPD, and there's a few just listed on here, and a few thinking about other differential diagnoses. Just have in the back of your mind all these other things that might be going on in this patient's life. Next slide, please. COPD, can you imagine trying to live with not being able to breathe properly by breathing through a straw all the time, or just constantly gasping for breath? It's bound to have a psychological impact on you. You know, you may stop going out. You may, you know, one of my patients had to move house into a flat, then it was further away from his social network. It all impacts on patients' psychological quality of life. So that is something that we need to, especially now with COVID, I think, concentrate very much on in this group of patients, thinking about their mental as well as their physical well-being, their relationships with other people and their communities, and how we can support them. Thinking about how we code all of this, and think about on the EMIS templates. They do have the patient health questionnaire, the PHQ depression scores, and although it's not part of the QOF recommendations, I think we should be all filling those in and asking patients how are they feeling. It goes back to the pulmonary rehab as well. A lot of these COPD patients have become really deconditioned during COVID, and any little thing that we can help with is going to improve their quality of life. Next slide, please. A very little bit about diet, as well as the exercise, and thinking about in this group of patients the BMI of less than 20. They do unfortunately have a poorer prognosis, those slimmer patients. Thinking about their diets and encouraging them having a high protein, high fat, small and often, with possible supplements. And there's lots of research to say that the cachexia and this is associated with an increased morbidity as well. For those patients with a higher BMI, there is some improved prognosis. Some research suggests that weight loss of 6.2% may be associated with improved clinical outcomes and increasing their symptoms of exercise and functional capacity. Vitamin D, I don't think anybody wouldn't be taking vitamin D at the moment in the winter, but the evidence suggests that if you do have significant low vitamin D, that supplementation of vitamin D does reduce the number of exacerbations in that moderate to severe COPD patients. So making sure that those patients are being prescribed vitamin D. I know that the government is handing out vitamin D for lots of patients now, aren't they? Next slide, please. I just wanted to put this in here if people haven't been aware of it. It's called the BODE Index, and there's a link on the you can just plug it in and do a little sort of questionnaire, and it is a unique screening system that actually uses variables to predict mortality. It's not something that you would do with your patient sitting in front of you, but it does give you a guide of, you know, what their prognosis might be, and there are some, as it says there, pitfalls with that. But some of the evidence there is actually if they've had two or more hospital admissions, we do know that they're much more likely to die within 5 years. It's a little bit more of a I don't know. It's something for you to look at, but and think about. I'm not going to go any further. Thanks very much. Next slide. The clinically extremely vulnerable patients, well, the beginning of the COVID was called the shielding patients. I've alluded to the fact they've got lots of deconditioning there and its effects on mental health. For me, just going to go into the whether or not we use oral steroids and antibiotics. But there was some discussion at the beginning of COVID about whether or not we start oral steroids, but only if instructed by the healthcare professionals. So it's very much in contrast to what they might previously be advised if they do have COPD and COVID. So this is quite an expert area, and hopefully the respiratory consultants will help us with our patients with COPD who do develop COVID symptoms. Next slide. Preparation for end of life. I think everybody that's working in primary care should be encouraging this age group and our patients to be doing a Coordinate My Care program and plan. That's talking about very difficult conversations, but important conversations to have with this group of patients about what would they want to happen towards their end of their life. There's the link there to Coordinate My Care. Patients can set off the record themselves, and then they can speak to their GPs about how to progress it. And a little bit there about that graph, you can see here we go, which I said last time using the Bode index, that frequent admissions to hospital reduce, and 2 to 5 years they often they have that accelerated frailty phase. So we want to be able to catch these patients before they get on that very steep downward path so that we can improve their quality of life towards the end. Next slide, please. And I think that's just a little bit about all our lovely apps we've got available. And the next slide, any questions, I think it is, before we go on to Famida.
We just had some questions about pulmonary rehab, but it's been confirmed that they are going ahead with virtual. We need to get the Camden website updated to reflect that. Has anyone got any additional questions they want to ask at this stage?
I had just one question. It's just Sharon here. It was just really for what other people do. So at the moment we have to put down whether people have had exacerbations in the last year. And as you mentioned earlier, often patients have asthma and COPD. I wondered what others were doing, whether they, because it's sometimes difficult to know, we don't always code exacerbations, but you'll look back in records and you'll see antibiotics and steroids or one or the other given. And I just wanted to sense what other people were doing in terms of how they'd code that. Would they code it as an asthma exacerbation or a COPD exacerbation or both? Just really interested in your thoughts. Thank you.
It's a difficult one, isn't it, Sharon, because there is that huge overlap. I think if they were a smoker and we went with looking at the number of antibiotics, I'd probably be coding that as a COPD exacerbation. And if they don't have that much reversibility, probably not code it as an asthma exacerbation. I don't think there's a right or a wrong. I think if you actually coded them both, it would actually highlight them as being a vulnerable group. And I think probably that's the purpose of coding, isn't it? To sort of highlight who are we needing to keep an eye on. I think I'd be very much pragmatic in my view. I don't know what Famida would say.
Yeah, I mean, I think the main thing is to code it. I think we're not been very, often we're not very good at coding the exacerbations. And I think I'd go with you, Jackie. If they're a smoker, probably more likely to code as COPD. But the main thing is to make sure you get consistent coding, throughout the practice.
Thanks both. That just helps me realise that, we're just trying our best at the moment with these things, and especially because it's new in the QOF areas to have to do that. So that's great. Thank you.
Thanks.
So thanks, Elastine, for answering about what people need for this remote pulmonary rehab, preferably a tablet or a laptop, but some people are using their smartphones. We've got a question from Sigel. Is everyone doing pheno-testing?
Not at the moment in our area, although there were some people doing it in secondary care. I think they were less worried about it being an aerosol generated procedure, but at the moment it's not happening very much. Thanks.
What about during non-COVID times? Are many people doing pheno-testing then?
We did a trial in Barnet a couple of years ago, and then it appeared that the sort of funding disappeared, which was a real shame because I was finding it hugely helpful. So I've got a redundant machine in my cupboard, which if anybody wants to donate some money, I'm more than happy to start using it.
Yeah, I don't think there's much pheno testing in primary care. I certainly, there's talks about hubs where, spirometry and pheno going forward, where that might happen. But
okay.
Yeah.
Thanks.
Shall we go on? Okay.
Okay, so thank you, Jackie, for that. So I suppose being a pharmacist, it's sort of appropriate to talk about medications and treatments. So Jackie mentioned earlier about GOLD and how we use GOLD for diagnosis. And actually, GOLD's quite good because it helps you quite nicely grade the extent of airflow obstruction. Once you have got a diagnosis, a formal diagnosis, or I guess, in the present climate, a sort of suspected diagnosis, you need to think about the treatment and the management options, and we have a number of guidelines available which we can use. They can get a little bit confusing as well, and I suppose some are a bit better than the others. So these are the two main guidelines that we use for COPD are the NICE and the GOLD. So actually GOLD is not really a guideline. It's more of a sort of a report. It's a report strategy, and it's recognized globally. It's for the global market. NICE is obviously for UK. Both of them are very similar. They are very similar in when they talk about diagnosis. It's all about sort of getting a good history of their symptoms, and relies on post bronchodilatory spirometry. But where they slightly differ is in the management. And NICE sort of the first choice, I suppose the first choice that NICE talks about is sort of bringing in the combination LABA/LAMA inhalers, whereas with GOLD it's more of a slower progression going up the treatment pathway. Then we have the PCRS, the Primary Care Respiratory Society. This is obviously not a guideline, but what they've done is they've sort of combined the two sort of to get the best of both and sort of have a more pragmatic approach to navigate through both the guidelines. So do have a look at that. It's on their website. So if we can have the next slide. So I will talk about the guidelines, but I think both of those GOLD, NICE, and the PCRS, they talk about the aims of the treatment are the same, whichever guideline you go with. So the main aims are to reduce the symptoms, relieve symptoms, improve exercise tolerance, improve their health status, and also to reduce risk, to prevent disease progression, also definitely try and prevent the exacerbations and reduce mortality. So the aims of the treatment are sort of the same, whichever one you use. Next, please. So this is the GOLD treatment guideline. I think earlier Jackie showed the other slide which had the sort of diagnostic in there as well. I tend to find GOLD a little bit more confusing, and the NCL do recommend go via the NICE guideline. So I will sort of focus a bit more on NICE, but just to sort of talk you through this, GOLD talks about using symptoms and number of exacerbations and hospitalizations to help determine what kind of treatment you would use. So if we have a look at GOLD, if you would look at the box 1, box A, this is somebody who has few symptoms and no exacerbations, and you would start them off with a simple bronchodilator. So it could be a short-acting one or it could be a long-acting one. They don't sort of specify. Looking at the group B, this is somebody who has slightly more symptoms. And so here you're using the MRC and the CAT score as Jackie explained earlier, but GOLD, remember, uses the MMRC score. So do be mindful of that if you are using this. So group B is somebody who is getting a little bit more symptoms, but still not many exacerbations, less than one or less. And then here you would use long-acting bronchodilators. So it could be a LABA, LAMA, or you could use the combination. Group C, Group C is a little bit unusual, actually. I don't really see many people in Group C, but Group C is somebody who would, somebody who doesn't have a lot of symptoms, but who's having, a couple of exacerbations. And that's sort of a bit, I guess I don't really see that group very much. And maybe you'd want to think about, is the patient sort of being active, mobile, are they very sedentary? So you might want to think about that. But in this group, it's the treatment options would be ICS, it's introducing ICS, and LABA or a LAMA, and there are some alternatives there. One of the ones that appears in Group C is PDE4 inhibitors. So these are phosphodiesterase 4 inhibitors. I won't talk a lot about this at the moment. I might just touch on it a bit later, but it's not something we use in primary care. It's secondary care initiated. So Group D is a very severe COPD. These are the patients who are having a lot of symptoms and a lot of exacerbations and maybe hospital admissions as well. So more than one hospital admission. And here you can go on to the triple therapy. So it's a little bit confusing. You can either use this, that, so it can get a little bit confusing. And NICE, I think, is a little bit more straightforward. And we can go on to that next. Thanks for that. So this is available obviously on NICE, on the NICE website, but also on the North London NCL website, and I put a link there. It's really nicely explained, and as you can see, interestingly, NICE actually talk about managing the fundamentals of COPD care, as Jackie explained earlier on. So it's looking at all the other options before you start on treatment. So looking at pulmonary rehab, smoking, all those conditions need to be looked at before you start looking at the inhaled therapies. So with NICE, there's more consideration given to thinking about the type of COPD patient you have. Does the patient have asthmatic features, or is it just mainly, with no asthmatic features? So if we just unpick a little bit with regards to the asthmatic features, what does that actually mean? So this is somebody who has a diagnosis of asthma or a previous diagnosis of asthma, somebody who's sort of got eosinophil count, so high blood eosinophil counts. Typically, we're looking at 0.3 or more. And I just wouldn't look at the first reading. It's worth looking historically back at previous readings as well. And also looking at FEV1. If there is a variation in FEV1 of more than 400 mils and a daily variation in their peak flow readings. So if somebody has those kinds of features, you follow a slightly different treatment pathway. Basically, you treat them as if they have sort of asthma, I guess. So if we can go to the next slide, please. So as I sort of, following on from the previous slide and thinking about the asthmatic features. So asthma and COPD are actually different disorders, but they can coexist in an individual. And they share certain traits, as I explained. So eosinophilia, it's really important to check that and see if they have got any reversibility. If they have these traits, as it's where you have to go down the sort of asthma pathway, so to speak. Now, we used to call this, some of you may remember, we used to say asthma COPD overlap syndrome, but we're moving more and more away from this now. So can I have the next slide, please, Sadat? So I'm just going to go through the NICE strategy. NICE, I suppose the first option is to offer a short-acting beta agonist or a muscarinic. So we're talking about salbutamol or ipratropium, although we don't see ipratropium used a lot nowadays, but you could use either one of those. Usually we see patients when they're a bit further down the line. Often they're already having more symptoms. But if somebody is already using short-acting bronchodilators and they're still getting symptoms and or having exacerbations, then the next thing we would do is, so if there are no features that identify with asthma, or there's no suggestion of steroid responsiveness, we can offer to move a combination of LABA/LAMA, so going straight to dual bronchodilation. And the thinking behind this is, to get the patient as mobile as possible to improve their quality of life. So you can go straight onto the LABA/LAMA combination. If they're still limited by symptoms, if they're still getting quite a lot of symptoms, you can consider a 3-month trial of the combination LABA/LAMA and introduce ICS at this point. There is some good evidence that patients who are if they are having a lot of symptoms, they actually sometimes do quite well on the ICS introduction as well. But this they suggest as a 3-month trial. If you find that actually it's not really making much difference, then you can stop the steroid at this point. The other sort of pathway to this is if they are having continuous frequent exacerbations, then certainly add the inhaled corticosteroids. And there is evidence to support that actually this is quite beneficial. And in somebody who is having frequent exacerbations, you'd be a bit reluctant to stop the inhaled steroid. The only thing I would say is that obviously, if they have had a hospital admission and confirmed pneumonia, you've got to be a little bit mindful of the steroid, because, as you know, inhaled steroids can lead a person to have a pneumonia. So you might want to be a little bit careful in somebody who has had a confirmed pneumonia, and certainly look at using the lower dose steroids. Now, if we go on to the next sort of type of COPD presentation, somebody who does have asthmatic features, you would introduce the ICS at this point, and it would typically be a LABA-ICS combination. And then the next bit would be if they're still limited by symptoms or having exacerbations, you go on to triple therapy at that point. So obviously, before you sort of move on each step, always important to check inhaler technique, make sure that the patient is able to use that the device. Are they using it correctly? It's really worth having having that discussion. And then obviously, if all of this has been tried, then and they're still exacerbating, then you might need to consider different options. Now, it's quite, as you can see, this is quite sort of clearer pathway than the gold. And I think more and more people tend to sort of follow this. But also remember that the person is sort of, it's an individualized treatment, and you have to go with what works for the patient, which is really quite important. Now, looking at
there's some questions in the chat which might be relevant for now. Would you like to, is that okay?
Oh, yeah, sure, of course, yeah. So I'm just having a look. Let me just scroll up.
So one question is, what does a high eosinophil count imply in COPD asthma?
So typically, patients with a high eosinophil count have a better response to steroids, and patients with asthma, so it's sort of allergic asthma, sort of inflammatory conditions, tend to have a higher eosinophil count. If somebody is your eosinophil count can be raised if you're sort of unwell, if you're having, if you're just feeling unwell, if you have a sort of acute illness. So it's really important to have a look at sort of as historically what the eosinophils have been. And you might notice that sometimes patients' eosinophil are sort of fairly normal, but when they're exacerbating, they tend to be high. And this tends to be in patients with asthma.
There's two questions. One from Karen, who's patients that they inherit have both asthma and COPD and on triple therapy for many years. It's hard to stop or reduce them. They often are being labelled with the evidence of asthma and no raised eosinophils. How is it best to manage them?
Yeah, so a lot of our patients, I think at the, about 4 or 5 years ago, a lot of them used to go straight on to triple therapy, and they used to progress very quickly. I think you need to be a little bit, so you need to look at the patient, and you need to look at to see if they have got obviously any asthmatic features or traits. Then obviously keep the steroid in. But if there is no evidence of that, then it is reasonable to try and have discussions with the patient and reduce. I wouldn't completely stop it straight away, but maybe reduce a sort of weaning off process to try and see that, but monitor them, you know, as you along that way. And we've got some really good dual combination LABA/LAMAs at the moment, which work quite well. I don't know, Jackie, what do you do in your practice?
I do know that the respiratory consultant in Barnet is trying actively to get that diagnosis right and actually cut down the steroid dose. So she's exactly what she said, is don't stop it yet, don't stop it immediately, but tailing down would be where I would go as well.
Yeah. And I think the next one is triple therapy inhalers should only be initiated. No, you can, with triple therapy, you can initiate this definitely in primary care. You don't need to wait for a respiratory input. And just remember that, you know, although this follows a pathway, a flow chart, it depends when the patient presents to you. You can start at any point in this pathway, but dual bronchodilator seems is a good start for somebody who doesn't have asthmatic features on there. But no, you don't have to wait for respiratory input.
Shall we go on?
Yep, we can go on. There's a few more questions. Maybe I can take them a bit later on. So this is the next. This is from the NCL guidelines. This sort of follows NICE guidelines, and what I really like about this is that it sort of got, it shows you the inhalers, shows you the sort of colors that are available. It's not very clear. I guess it's not very clear in this slide, but you can have a look on the website. And if you look, just second paragraph, you've got the short-acting bronchodilators, where we've got salbutamol and ipratropium. As I mentioned earlier, we don't tend to use ipratropium that frequently at the moment nowadays, but you will find some older patients are on that, and that can be used up to 4 times a day. Also to note, there is salbutamol, which is a dry powder inhaler. So if you go a bit further down in the next step, the next sort of step down, you've got 2 choices. You've got first line and a second line option. So you've got in somebody without any asthma features, you've got that combination LABA/LAMA, which is the Anaro Ellipta, quite easy to use. But they've also, as a second line option, got MDI, the Spiralto. And I really like this because, you know, it's got the option of a dry powder and a meter dose inhaler. A lot of the inhalers for COPD tend to be dry powders. But what I often find is, you know, obviously some patients might not be able to use that, but especially when they're having an exacerbation, I often find that some patients are really finding it difficult to use the dry powder. And I often give, I sometimes give MDI for them to use, equivalent MDI to use during their exacerbation. So we've got that in the non-asthmatic patients. And if you go to somebody who has sort of asthma features, we've got Foster there. As a ICS LABA combination with any MDIs, really important, especially for, you know, for everyone, but for COPD patients to use with the spacer. And then you've got the option 2, which is a dry powder, the Valva Ellipta. Then going further down, if you need to go on to triple therapy, again, you've got 2 options there. You've got the Trilogy and you've got the Trimbo. So dry powder and also the MDI. The good thing about using these fixed dose inhalers, so either the, you know, especially the triple therapy inhalers, it's always good to go for these combined triple inhalers, because that way you can ensure you're not over sort of treating the patient with the steroid. You're sticking to that fixed dose of steroid, which is safe for a COPD patient. You want to avoid going into high dose inhaled corticosteroids, and using the fixed dose inhalers are really good at helping you do that. The other thing is always remember to prescribe by brand. You know, salbutamol, certainly you can prescribe generically, but all the other inhalers, really important to prescribe by brand as well. We have the next slide. So obviously that was the NCL, what we've got on the NCL, and it keeps it very limited. It keeps keeps it quite nice and clear, so you don't have too much choice. It's not too confusing. But this is just another sort of all the other inhalers that can be used in COPD. And obviously, you must have patients who on Symbicort and Duoresp, tiotropium. So there are others that you can use, and certainly you need to go with what works for your patient. If something's working, if they're on tiotropium and it's working with this Spiriva, then certainly continue with that. The Right Breed website is excellent. This is my go-to place when I come to looking for inhalers. It's really easy to search. You just have to put, if it's for COPD, whether you're looking for LABA/LAMA, whatever combination, you just put that in the search and it'll bring up the inhaler. So please do use that if you haven't already. Next slide. So other treatments. So considering other treatments, just very briefly, mucolytics. So only really consider mucolytics for patients who really having, some of them have a lot of sputum, which they find difficult to cough up. It's really sticky. Not much evidence for it. It does work in some people. So what I tend to do is I tend to give a trial for a month and see if it improves their symptoms. And if not, then you can stop it. Some patients are quite good. They'll use it during their exacerbations and not all the time. It does have sort of gastrointestinal side effects. So it can give you a bit of indigestion, a bit of bloating. Just be mindful of that and just warn your patients on that. So it's not a game changer, but it can help. I've added theophylline in that. Theophylline is actually, I've crossed it out as well. I wasn't sure whether to put it in, but you might have some elderly patients or some of your older patients who are using theophylline. Not used now that much. Little evidence base for it, especially in COPD. And I guess, there is a high potential for drug interaction, especially for the elderly. Now, prophylactic antibiotics. So I've put that here rather than in the exacerbation one because it's more for sort of treatment, I suppose. So a lot of you possibly have patients who are on azithromycin 3 times a week. I would certainly consider having a respiratory input before you start somebody on prophylaxis antibiotics, and make sure you've got the sputums, including for TB, that they've had the sputum cultures done. But before initiating that, make sure that all the other treatments have been optimized, they've had their vaccinations, pulmonary rehab, and possibly think of these for patients typically on more than 4 exacerbations a year, or who've had more than 4 a year, or have been to hospital. Doesn't tend to work so well in patients who smoke. There's I think there was a sort of study that showed it didn't have any impact. So not to use in patients who are still smoking. Next slide. So I'm not going to dwell on this too much, but just so you're aware, these are the other treatments. Oxygen, saturations, if they're having less than 92%, then certainly they need referral to the community COPD teams who will do the assessment on that. The romlufmifast, I can't pronounce that. This is the PDE4 inhibitor that I mentioned earlier. Again, this is secondary care initiated. It works reducing inflammation, but different to the way a steroid works. And certainly this is severe, that it does have some severe side effects, especially with depression, mood, suicidal tendencies. So it might have some patients who are using that. Next slide. Okay, so exacerbations. So this is just a little slide that just shows, the trajectory of somebody who has exacerbations. They are extremely they are serious, and they do lead to a decline in FEV1 and also increased mortality. So really the aim of our treatments is really to prevent patients getting this. Yeah, next slide. So I guess before you sort of start treating for exacerbations, you want to consider why they're happening. And I think I've got the slide a bit later on. But really, a definition of an exacerbation is a sustained worsening of the patient's symptom from their usual state, which is beyond their normal day-to-day variation, and it's an acute onset. Patients with COPD have symptoms all the time. They have symptoms day in and day out. So it's really recognizing that this is beyond their normal symptoms, and it's really important. So there'll be, so the main symptoms would be a worsening breathlessness, a cough more than normal with increased sputum production, and the sputum would be more volume, but also be more sort of purulent, so it would be sort of green, and a lot more, and possibly maybe some hemoptysis as well. So change in sputum color is really often noted as well, but the main thing is it's more than they normally get, and it's worth considering, is this just a bad day, or is it actually an exacerbation? But if you have decided that, yes, this patient does need treatment for the exacerbation, then if I could have the next slide, please. So how do you then go about treating it? So the first thing I'd say is increase their SABA use with the spacer. So they can use this 2 to 4 puffs, every 4 hours, 4 times a day. Sometimes if they're having a bad day, just using more salbutamol, it sort of sorts them out, and then the next day they're fine. But if you do need to go to starting oral steroids, and again, it can be, the steroids you would use if they're sort of very breathless. And the dose is 30 milligrams for 5 days. This is different to asthma. In asthma, it would be 40 milligrams, which we'd be using. But in COPD, it's 30 milligrams. That you would use. If they are also producing a lot of sputum and it's purulent, you might want to consider 5 days of oral antibiotics. So the first line is amoxicillin or doxycycline. Actually, I've just sort of, doxycycline is for 5 days, but I still see a lot of prescriptions being prescribed for 7 days. So it's actually 5 days. There's no evidence that using more than 5 days has any benefit. The patient will take a bit longer. To get better can take up to, it can take up to 3 months to get back to your baseline if you do get there. But the exacerbation, they will probably, won't feel completely better for about 2 weeks. So patients might come back and say, oh, actually, I need more antibiotics, but it's probably worth just reassuring them that it does take a little bit longer for them to feel better, but it's 5 days. And if you need alternate antibiotics, then you can go into the sort of co-amoxiclav or co-amoxiclav. It's really important to safety net the patient, and really giving them sort of proper advice of what to do if they don't feel better. So sort of giving them sort of contact numbers. If it's a weekend, telling them to contact NHS 111. You might want to follow them up in 24, 48 hours, but really giving them clear advice that if your symptoms do not improve within 2 to 3 days, or if they're getting unwell, or if they're getting more systemically unwell, they need to either contact you, ring you for an on-the-day appointment, or arrange a follow-up. Sort of arrange a follow-up anyway after a couple of weeks, probably about a week after they've started their treatment. But safety netting is very important that the patient understands. Okay, next one. So Jackie talked about self-management plans and rescue packs, and as she said, we probably don't use them enough for COPD. And I think there's so much to do with COPD, isn't there? There's so many things to consider. You've got the CAT scoring, and then you've got the MRC score. What we tend to do now in our practice is we send those ahead as a AccuRx message for patients to fill out those kind of tests beforehand, so it sort of reduces time, and you've got actually more time to deal to discuss self-management plans. But make sure that the patients have you've agreed an action plan, and this may or may not include a rescue pack. So there might be some patients who probably might be not suitable for a rescue pack. They might not understand, so they need to have a system whereby they can request an on-the-day appointment, and you need to maybe ensure that in your practice, maybe keeping a couple of appointments free a week to see these patients. If you are going to issue rescue packs, you really need to make sure that they understand how to use it. Do they need their steroids? Do they need to start their antibiotics? So really need to make sure that the patient understands. There are lots of information leaflets available. British Lung Foundation do some really good ones, patient information leaflets, so worth having a look at that. I certainly wouldn't advocate adding the rescue medicines on a repeat list. I think that used to happen a few years ago, but certainly I think most practices probably don't do that anymore. And importantly, make sure that you reviewed the patient in practice after the exacerbation, and make sure you log it as an exacerbation, you know, and read code the episode and discuss the next steps. Next slide, please. So this probably should have come just before the exacerbation, but really you need to consider, you know, why is the patient still exacerbating? Have you, you know, is the treatment working? Are they on the right treatment? Is the, you know, are they able to get the drug into their airways? Have you got the diagnosis right? You know, are they progressing a little bit further in their disease? And again, inhaler technique is key, obviously, to get the medication in. Making sure that they've had all the other interventions like smoking, cessation, avoidance triggers, vaccinations, and the other factors to consider, anxiety and obesity as well, because that can sort of often present, you know, anxiety, just like in asthma, can often present with breathlessness, and patients can think that they're actually having an exacerbation. You know, or could it just be that the patient is having a bad day? And I think, you know, trying the salbutamol initially for the first sort of 12 to 24 hours is worth doing. And often patients also know themselves quite well what's, you know, how they're doing and whether they're actually getting worse. Next slide. So it's mindful of time. Okay, so so this is a little bit about the UCL partners and NCL. They've sort of, you probably have seen that because I think it was discussed in the diabetes and also in the asthma one. But it's just, I think with COVID, we're not seeing our patients not seeing or talking to our patients as frequently for their long-term condition management. And UCLP have come up with how we can risk stratify patients and see those or talk to those that need more timely discussions. So it's really, if I can have the next slide. So we haven't included everything here, but it's on the NCL website and it's worth looking. For COPD, you've got 3 groups. So group 1 is, you know, the very high risk groups. They're probably under secondary care anyway, but those are your high risk groups. You need to make sure that they've got all the sort of self-management plans in place. I'd say similarly for the group 2 as well. Possibly group 2 are more of the ones that are important because they won't be under secondary care. So these are the people, and it's actually using the whole team, the whole multidisciplinary team. I think this is one of the sort of main things about this UCLP document is using the healthcare team. So it could be the healthcare assistants, it could be the pharmacist and GPs, each one doing what is within their sort of within their competency. And this is just a little bit about why they're high, medium and low risk. So have a look at that document. It's on the NCL website and the searches are already on EMIS, and we're looking through them in our practice and certainly looking at the high and medium risks and seeing if we need to call them in over the next few or speak to them over the next few months. So I'm sorry, it was a bit of a whistle stop there, but I think we've got time for some questions, haven't we? Yeah, oh sorry, there's a few more slides. So here, the good resources on the website as well, on the UCLP website. Can I have the next few slides? So again, this is the right care pathways. I highly recommend that you have a look at this. A lot of resources available on this. And the next one. This is the Primary Care Respiratory Society. This is again sort of extra reading if you're interested. Really good document here, population focused framework. Next one. And just some links as well for you guys. Okay.
Thanks so much, Famida and Jackie. Has anyone got any questions? Please do put your hand up, unmic yourself or unmute yourself rather, or pop it in the chat. I have to say, there's been so much information given. I imagine you probably comprehensively covered a lot of what people were thinking.
Yeah, somebody asked the SABA or SAMA as initial therapy. Yes, it would be just one or the other. It's one or the other, not both. So
well, you're getting lots of thank yous in the chat.
Okay.
I think there was one message from Darush. He was talking about carbon monoxide monitoring with the smokers. That is, I think, possibly there's a new guidance about whether or not we can start doing that again. So that's just an extra bit of information.
Yeah. And I think, yeah, if you've got somebody on triple therapy exacerbating frequently, do consider respiratory review, specialist review, sort of referring them on to secondary care. Yeah, can't see any more questions.
Well, thank you very much. I like the person who's put excellent in capital letters. I think that was really, really helpful for people. And, I think the slides will be a valuable resource for people to refer back to, because there's a lot of information to take in. So thank you very much for your time in preparing and delivering that for us today. Thank you very much. Thank you, Famida. Thank you, Jackie.
Thank you.
Bye.
Yeah, bye-bye, everyone.